Welcome back. Today we're talking about tobacco cessation and tools that you can use during your primary care visits to help your patients stop smoking. We're mostly focusing on the pharmacotherapy that we use, but also talking about some of the guidelines. If you're watching this video, then you probably don't need more reason to help your patients stop smoking. But the question is, how do we do it? As a new nurse practitioner, I was so overwhelmed with all the resources that were out there, and I can only imagine if my patient Googles how to stop smoking, how many things they might be inundated with. I'll link to some tools that I use in practice, but let's start with the big picture. The U.S. Preventive Services Task Force has an A recommendation to screen for smoking and help adults stop smoking, and a B recommendation for teens that haven't started yet. They came to an inconclusive rating for teens that have already started smoking, but obviously if I catch a teen in practice that's smoking, I'm counseling them on cessation. We'll start with a couple of cases. Our first patient, a 48-year-old male here to establish care with you. You've screened for tobacco use and determined that he has a 35-pack year smoking history. Your next patient, a 58-year-old female, has a 40-pack year smoking history. She's here for help because her brother was recently diagnosed with lung cancer. She's motivated to quit, but as you're reviewing her chart, you see that she has a history of major depressive disorder, which is stable on sertraline. She also has a history of coronary artery disease. How might these affect your management? And more importantly, how would you start the conversation walking into the room? When I talk about medications for smoking cessation, I'd lump them into two buckets. There's the controller or maintenance, as well as something for PRN or breakthrough craving. Your controller or maintenance medication is going to be something like the nicotine patch, bupropion under brand name Zyban, or Varenicline brand name Chantix. For the most part, the PRN or something for breakthrough craving is going to be the nicotine gum or lozenge. Some people use the nasal spray. The nicotine patch is relatively straightforward to prescribe. You dose it based on how much the patient is smoking, although we frequently underdose it. They come in 7, 14, and 20 milligram patches. You apply it to the skin, and classic teaching is to take it off 12 to 16 hours later. The reasoning being it could cause vivid dreams. But I don't usually do that because patients have wake up with most craving. And so if anything, it's cruel to make them take it off and then wake up with more craving. So if they report adverse events, then we would consider taking it off at night, but I usually recommend they leave it on all night. You frequently hear about not starting a nicotine replacement therapy if the patient's already smoking, but if they do end up smoking while they're taking it, it's not like they're going to overdose because they know what the effects of the nicotine are, as if they smoke too many cigarettes, so they'll just titrate accordingly. The next medication on our list is bupropion, commonly known as brand name Zyban for smoking cessation, and you may know it as Wellbutrin, used in major depressive disorder. Bupropion isn't necessarily first line. It can cause some agitation and insomnia, and we'll talk more about neuropsychiatric events later. It's contraindicated if there's a seizure disorder, and we usually start at a lower dose, 150 milligrams once a day, and titrate up to 150 milligrams twice a day. Since we're talking about bupropion, it's really important to remember the three different types. They always confuse me as a new nurse practitioner, and if anything, just go look it up if you don't remember. The immediate release, commonly known as hydrochloride, 12-hour release, known as SR, and 24-hour release, XL. Finally, we have varenicline, which is brand name Chantix. It's a little bit trickier to titrate because you have to start at a low dose, a half milligram once a day, and go up over a week to a total dose of 1 milligram twice a day. 1 milligram twice a day is the FDA-approved dose for varenicline, but we'll talk in the next video about using even higher doses. There's so many options for pharmacotherapy for smoking cessation that it's imperative we talk to our patients about this. When I start varenicline for patients, the most important part is just explaining the titration and giving them a lot of anticipatory guidance about what they can expect. Most common are a little bit of dry mouth or stomach upset, but I do hear a lot from patients that it can cause really vivid dreams. In practice, you can use a lower dose and titrating it to side effects if it's bothersome, although some patients get used to it. Varenicline acts directly on the nicotine receptors and reduces craving. So for any of the patient in the pre-contemplative or contemplative state, even thinking about quitting smoking, we go ahead and start it, and we find that the rates of abstinence among those patients that have started varenicline is much higher, even if they weren't quite ready to quit when they did start it. There's numerous clinical guidelines supporting our practice for tobacco cessation. I'll start with the 2020 American Thoracic Society that really has varenicline as their first line, recommending it over bupropion of the patch, and they also recommend adding varenicline to the nicotine patch for those patients. For patients not ready to quit, they're also recommending starting varenicline. I like the ATS guidelines because they do have a recommendation about going straight to varenicline, even in patients with psychiatric illness or substance use disorder. We'll talk a little bit more in the next video about some of the evidence behind this. Classically, we're taught for just 6 weeks of maintenance therapy for tobacco cessation, but really we want to push it over 12. We see a lot higher abstinence rates if we can get to 12 weeks of the maintenance therapy. Additionally, the 2018 American College of Cardiology guidelines have varenicline listed as first line. They recommend combining it with nicotine replacement therapy. If not, just nicotine or bupropion are a good second line. The 2020 Surgeon General report is also a great resource with a lot of behavioral interventions. If you like all the acronyms and letters and whatnot, you can think of the 5 R's or the 5 A's model. The 5 R's stands for addressing relevance, risks, rewards, roadblocks, and repetition. This comes from the Agency for Healthcare Research and Quality. There's limited evidence on these behavioral interventions, but I always give my strong recommendation that they should quit smoking. Our patients do trust us. The 5A's model is a little bit more common. You may have heard of it. For asking about tobacco use and advising to quit, assess readiness for their tobacco cessation attempts, and assist in the quit attempts. And then, of course, arrange follow-up. What a lot of these guidelines also allude to is not just the maintenance or controller bucket, like I was mentioning, varenicline, nicotine patches, or bupropion, but also adding something PRN for breakthrough craving. This is usually going to be the gum or the lozenge, sometimes nasal spray. There's a few studies on your screen here that show the increased efficacy of adding for PRN breakthrough craving. For example, a review in 2019 that looked at 14 studies over 11,000 participants. You add the gum or lozenge to patches, and you get increased crit rates of 25%, or a relative risk of 1.25. You'll hear a lot about the neuropsychiatric events, such as increased suicidality with varenicline and agitation and insomnia, like I mentioned with bupropion. We'll talk in the next video about the Eagles trial and some other upcoming evidence that really supports the use of these medications as first line, even in the setting of psychiatric illness. When I last checked Lexicon, there was no black box warning. Obviously, you want to look these medications up as you're prescribing them for the first few times. You want to be cognizant of any history, but don't be shy about using them. So now that we've covered this bird's eye view of pharmacotherapy and some brief behavioral interventions for helping our patients stop smoking, think back to our cases and how you might approach that conversation. In the next video, we'll dive into more of the evidence, specifically the Eagles trial, which covers use of varenicline and bupropion in the study of psychiatric illness, as well as some newer evidence about using high-dose varenicline, which has an even higher success rate. In the meantime, go check out the guidelines that I mentioned in this video and really feel more comfortable prescribing varenicline, bupropion, nicotine patches, as well as nicotine for breakthrough craving.